what do you think are the main or key topics you are working on and challenges for the future in your work?
Right, well, thank you for asking. We're now towards the end of our first phase of the program, and what we've learnt from our experience working in 4 different countries, in Cambodia, Sierra Leone, northern Uganda, where there are post-conflict situations, but also in Zimbabwe, which had a major crisis. We first of all looking at the health systems in terms of both the supply and demand, the demand side being from the community, and looking at how communities have changed as a result of these crises or conflicts. And so the first thing we would say is you need to understand more about the nature of that community, how it's been affected, and it will be different in each situation. But for example, you may have a situation where many of the males are no longer on the scene because of conflict, a much greater number of female-headed households, and we need to think about how they access healthcare, how they get the money to access healthcare. You may also have child soldiers who have been involved in the conflict, and the implications of that may be much later when the parents are getting old. Who's going to look after them? So there are a lot of things one would want to look at in the community. Also the dynamics, the power dynamics within it. When thinking about how you develop, how you design systems and services to provide healthcare that they can easily access. The second thing we would talk about is institutions, and here we're not just talking about organizations, but we're talking about rules, relationships within the health system and related to the health system. And often where there's been a big crisis or conflict, you'll have a big external influx of organizations coming in wanting to fix things quickly because of the humanitarian need. And that will have implications for the health system much further down the road as it evolves. One of the things that will happen is probably because these agencies come in with a lot of money, the power shifts. You may already have a weakened national agency such as the Ministry of Health because of the conflict, unable to make decisions even for the short term, but definitely not strategic ones for the long term. And so they may get crowded out, and plans or the development of the health system is set in a direction which later causes problems. And examples of this might be whether you decide to contract out service delivery, maybe to different private sector NGO providers and so on. And that will have implications for later when the government is trying to regularize the situation. And we need to look at those power relations, and part of the power is knowledge, is understanding what the situation is. And through Rebuild, we're helping local researchers be able to develop that information so that they can support their ministries and so on with the decision making. The third area that we worked on is human resources, which, as I should have said earlier, what we're looking at is health systems that are pro-poor. Therefore, we're talking about equity, and of course, you're immediately then talking about staffing. Even in non-crisis countries, you have problems of staffing in remote and rural areas. So one of the things that happens with agencies coming in, they need people to work for them. That immediately has implications for the labour market. And what it tends to mean is that donors have to pay higher rates. So when they withdraw, it's difficult then for the government to bring those people back into service. They've been used to better funding, better incentives and so on. So there are issues around incentives, motivation, but there are also issues around the administrative systems used for managing human resources. The one that we looked at particularly was the posting and transfer. How do you allocate staff to where they're needed? And that's particularly important when you're thinking about pro-poor, to ensure you've got equitable distribution. And what we've learnt is that in the conflict crisis period, the national level has not been very responsive. Policies haven't changed, even though the need has changed. But what you've got is maybe we could say more resilient managers at the middle level, often at district level, and the way they interpret those policies in a sensible way that allows them to keep health workers in places, so they don't send them to dangerous places where they know that the health workers will then refuse to go to. So they're being pragmatic about it. And so one thing we could say is that, you know, if you have those crisis periods, you support those managers, not just for human resources, but a lot of those decisions that are made at the sort of mid-level, because faced with challenges, managers will very often make the right sort of decisions. Just finishing on human resources, one of the things that you might look for as you come out of conflict, there might be at some stage an opportunity for improving systems. And it's a very important point when you're thinking about human resource strategy to think about how you incorporate ideas of gender equity into that process. So there may be opportunities. We've also seen in terms of crisis, sometimes you've got really quite a resilient workforce who've learned a lot of skills because of the need, and so those could be used at a later stage. So we know that there's a lot more to learn, but our focus, if we were talking to people, would be thinking about the community, thinking about the institutions, thinking about human resources. There are no right answers what you do, but if you understand more about what has happened and the way they've evolved, then the strategies for improving health systems become a little clearer and maybe a bit more obvious.